So we all know that total knee replacement has been the gold standard for osteoarthritic knee for quite some time. And we see the patient, we assess the grade of arthritis and symptoms, and we just offer them total knee replacement. So the question comes in, why partial knees? And that's because of this slide. Quite often we see the picture in the middle, medial osteoarthritis, most common for obvious reasons that orthopedic surgeons know. And also we see general osteoarthritis in inflammatory disease, plus in some arthritic knees. But there are instances when we see unusual x-rays, and that are at the bottom, where we see only patellofemoral arthritis and then only lateral compartment arthritis, or you feel sometime perioperatively or on the x-ray that, well, the lateral compartment of the PFJ was quite pristine, but because you're trained to do total knee arthroplasty, you just go ahead and do the procedure and don't think about it much and say the patient would be happy. So the thought process of selected knee replacement has been there for quite some time. It's not that we are talking of it now, although the indication and the designing has been evolving over the period of years. But you can see that McKeever and McIntosh in 1950 thought about it, and they put in a metallic tibial component only. And then we had the Mermer knee, 1972, metallic femoral component and a polyethylene tibial component. And it kept on evolving till we get the modern meniscal bearing and a fixed bearing partial knee replacement on the medial side as well as the lateral side. For the sake of clearance, I'm not talking about a PFJ at the moment, and the lateral uni would be talked about by my colleague, Dr. Umar Bhatt. So if you think about it, it's straightforward. You say, well, it's a small operation. You will have less pain. You will have same on next day discharge, fast and easy recovery, and it's quite attractive for granddads and grandmas who are struggling after total knee replacement for quite some time. And it saves 2/3 of your knee and on the ligaments. The feel looks like a natural normal knee. Less blood loss, less morbidity, lower rates of prosthetic joint infection, lower rates of wound complications, and low cost. And these are not just because I am presenting it here. There is a lot of evidence that partial knee replacements ends up having these things as compared to a total knee replacement surgery. Then comes the candidate, which is then comes the question which is very important in this, which is the selection criteria for partial knee replacement. So that also is an evolution. Cozen and Scott were the first who were very selective in offering partial knee replacements, and they showed good results if they were adhering to this strict criteria of isolated, reasonably isolated clinically and radiologically isolated medial or lateral OA, age less than 60 years, angular deformity less than 15 degrees, which is passively correctable to the neutral on clinical examination, no flexion contracture or flexion contracture less than 5 degrees, and range of motion more than 90 degrees. And they were saying that if you adhere to these strict criteria, the results are going to be good. So do not stretch your indications for partial knee replacement if you want to have a good result. But over the period of time, as the technique and the implant design improved, there were surgeons out there who were stretching their limits to offer partial knee replacements. And they were offering it to active patients with a weight even greater than 82 kg and PFJ osteoarthritis. And the claim was, well, you don't replace patella in most of the knees. And unless you have a bone-on-bone situation on the skyline view, especially on the central facet and the lateral facet, you can offer partial knee replacement to these patients as well. And they actually demonstrated similar survival rate as compared to the Cozen and Scott criteria on the previous slide. So partial knee replacement possibly has been in a lot of debate because of ideal indication. And there are areas which are gray areas. Some people would have their own priorities. Some people would stick to the other side of the coin. Age and activity level basically dictates the chances of revision, because you would have an operation which has been done to one side of the knee and you have left two other sides which possibly can go arthritic with time, or your one side of the knee can go loose. Obesity, there are papers out there who would say, well, even in obese patients, partial knee replacement can work and the results are good. But I must say that you're not going to offer it to patients who are morbidly obese with a BMI of 35 or 40. But you can offer to them and stretch it up from 25 to 30 maybe, plus the bone quality and the associated comorbid condition like diabetes. So I would say if you have diabetes plus obesity and other problems, then you're not going to do partial knee replacement on that lady or gentleman. Lateral compartment osteophytes, when we see these x-rays, people talk a lot about lateral compartment osteophytes. I have started doing them 2 years ago, and when I present them in our sectional meeting, you can see the raising eyebrows. Well, you've got a big osteophyte down there, so how can you do only partial knee on the medial side? And the answer to that is that if you're really concerned, and it's a genuine concern, then the recommendation would be to have a valgus stress x-ray to actually dictate the thickness of the cartilage on the lateral side rather than having an osteophytes which is bothering you. So lateral compartment osteophyte in itself is possibly not a contraindication, but it raises a concern, and if you have that concern, you could do some additional x-rays or maybe the MR imaging to assess that. For inflammatory arthritis, it should be a straightforward no. You can't do partial knee replacement for inflammatory arthritis. Chondrocalcinosis, some people would do, some people would not, and that is related to the claim that if you have chondrocalcinosis in your knee, there would be some inflammatory component to the knee joint itself. PFJ symptoms, as I said before, if you have classical symptoms of the PFJ arthritis on clinical assessment, and if you can see bone on bone in the skyline view with lateral and central facet involved, then yes, you should not do partial knee replacement. So there's another criteria which Goodfellow devised in 2006, and they recommended that if you have bone on bone in medial compartment with a functionally intact ACL and MCL and full thickness cartilage in the lateral compartment, then regardless of age, you can do partial knee replacement to that particular patient. But yes, you should not do them on inflammatory disease, ligamentous instability, uncorrectable varus deformity, absent ACL, history of HTO, or severe wear of the PFJ. Then comes the question, survival of the medial uni knees, because I said we are going to talk about medial uni. So there are some papers which have shown that if you have partial knee replacement in relatively younger individual, the chances of having reoperations would be higher, which makes sense. So UKR provided better functional outcomes in all age groups, particularly the younger patients, because they are high demand and they want to get on and do the jobs quickly. Although in older groups, TKR tended to have a lower revision rate, in the younger UKR had a lower revision rate. That is interesting, but that is because in this paper they reflected on the fact that they were offering it to the patients who are really bone on the medial compartment. It's just like when you do total knee replacement in a relatively mild arthritis situation, then you are guessing that the patient won't be too much happy about it. So the same stands true for partial knee replacement. You need a bone on the medial side. Then clinical orthopedic related research presented this paper, and the all-cause survivorship ranged from 90 to 98% at 5 to 10 years of follow-up after TK and 90% at 10 years of follow-up after unicondylar knee arthroplasty. So the bottom line is, as the age increases, the survival gets better. This is another interesting paper, which is a matched comparison of long-term outcomes of total and unicompartmental knee replacements in different ages based on national databases. And it's the analysis of data from National Joint Registry for England, Wales, Northern Ireland, and Isle of Man. So it is kind of interestingly reflecting on the same fact again, that if you have advancing age with a partial knee replacement, the chances of reoperation gets lesser, but your complication rate is also less. But in younger individuals, the chances of reoperation is higher versus the mortality is still low. So I think, given the papers that I'm presenting, I am able to clarify what we are talking about here. So I would say that I have been starting it for the last 2 years, and the more I do it, the more I am believing on it. And the indications, you are always stretched as an orthopedic surgeon to expand your indications. That's our inherent bias as a surgeon. But I would say that it's a different operation with a different mindset as compared to total knee arthroplasty. And what I mean is, when you're doing routine total knee arthroplasty, you used to get a big incision, you just cut everything off, you do the job, and you go home. But in this operation, you have to be a little careful. It's an unusual situation. You have a little incision, a tunnel in there, and you're trying to work out. You have MCL, you have ACL around, and basically it's kind of resurfacing without disturbing the knee. So if you do that job for a properly selected individual with regard to age, reasonably sure that it's medial compartment only, and you have counseled the patient, then it's a good operation, and it should be on the offer of various operations as an orthopedic knee surgeon. Thank you very much.